Hello, we are going to get started. So welcome everyone. So good afternoon or good morning from wherever you're joining us in the world. So thank you for registering and coming along to our Global Tracheostomy Collaborative webinar series. So it's our April education series, and we are covering creating and sustaining a high reliability trach team. I'd like to start by acknowledging and thanking our sponsors, so Smith Medical and Medtronic, for supporting these webinar series and education series. So we welcome all of the delegates that are returning and all of the new delegates and families, clients that are joining us. So we thank you for your attendance and your contributions to advancing tracheostomy care and education. So my name is Dr. Amy Freeman Sanderson, and I'm a speech language pathologist, currently chairing the education committee. So I will be hosting this webinar, and it will be moderated by Dr. Michael Brenner. Well, we have a couple of objectives that we want to cover in this hour. So we've got describing different models of tracheostomy teams across paediatric and adult populations. We'll be discussing roles and team effectiveness for tracheostomy management, sharing outcomes related to clinical care across adults and paediatrics, and lastly, considering approaches to developing and sustaining tracheostomy teams. So hearing some great examples. Over to you, Michael.
So we've got a phenomenal panel today, including some of the charter members of the Global Tracheostomy Collaborative who've really been pioneers in redefining standards for high reliability trach care. So we have Elizabeth Gould, who's an ENT clinical nurse specialist at UC Davis Health. Dr. Christopher Baker is a pediatric pulmonologist and director of the Ventilator Care Program at Children's Hospital, Colorado. Jessica Dawson is a new graduate nurse on the inpatient pulmonary unit at Children's Hospital, Colorado. And then Winston Menimitim, MD, is a neonatologist at Children's Mercy and a professor of pediatrics at University of Missouri, Kansas City School of Medicine.
Thanks, Michael. So introducing the topic, I wanted to really define tracheostomy teams and set the scene. So we all know that tracheostomy management is complex, and assessment and management occurs across a continuum. So I mean, in this diagram, we've got considering the acute setting where the tracheostomy is placed, but right through to that transition home into the community. So management at different points is needed across that continuum. We know from published research, so Barbara Bonveneto's work and McGrath et al., that fragmentation of teams can lead to delay in management and also raise some safety concerns. So team cohesion and working in a coordinated care setting is really vital for optimizing outcomes. So in terms of tracheostomy teams, I wanted to just highlight and recognise that there are many members of the tracheostomy team and really vital roles. So to make sure some of those were clearly articulated. So of course, most importantly, it's the person with a tracheostomy and the family and supporters, the caregivers as well. So looking at having them as vital team members and really the core to our team. We've got respiratory and physiotherapists, and I know there's some global practice differences, so acknowledging the role of both RTs and PTs. Speech and language therapists in regards to swallowing and communication, so really assessing and managing those vital aspects. Nursing staff and specialist nursing staff as well, so we'll be hearing from Elizabeth and Jess, but also acknowledging some of those other aspects of nursing, particularly in regards to stoma care. Psychologists, medical staff as well, so a variety of medical and surgical team members. We know that different medical specialties may be consulted along a person's journey, so acknowledging different team members. and also other members of allied health. So we have important roles with occupational therapists, social workers, dietitians, and I suppose broadly outside this circle, all the administration support, all of the other supporting clerical admin that also help us coordinate care. So acknowledging that broader net and team membership as well. So tracheostomy teams across the various centres work towards different goals of cares. So in terms of team members, we need to develop and co-design goals with our patients. We need to evaluate them. We're really utilising this framework, so the International Classification of Functioning. So we're looking at not only body systems, but we're looking at functions. So how is function altered for a person with a tracheostomy? So for example, functioning of communication, being able to participate in a classroom lesson or participating in a conversation. We have, and that participation needs to go across a range of contexts as well and environments. So just in terms of having our framework of goals, keep in mind that some of the work that we'll be presenting. So with that introduction, the lens that we're setting for this particular team that we wanted, or this talk that we wanted to capture, is representing pediatrics and adult populations. So to make sure that we could have some examples of different teams across those various ages, and again, looking at acute to community.
Well, terrific. Thank you for that introduction and background, Amy. And now I'll introduce our first panelist, which is Elizabeth Gould. Elizabeth is the tracheostomy and ENT clinical nurse specialist at UC Davis Health in Sacramento, California. She coordinates care and education for adult tracheostomy patients throughout the health system. She's created the inpatient tracheostomy team comprised of respiratory therapists to standardize patient care, support clinical decision-making, and provide a hospital resource for tracheostomy patients, as well as their providers. As the coordinator of the tracheostomy team and one of the clinical resources, Elizabeth focuses on high-quality patient care, reducing tracheostomy complications, and supporting complex tracheostomy patients and their long-term management. Elizabeth participates in the outpatient ENT tracheostomy clinic to provide continuity of care for patients navigating the health system. She also has a focus on head and neck cancer patients and works with the ENT service to optimize their care and patient experience. Elizabeth has been in her current position for 5 years and has worked at UC Davis for over 15 years with a background in ICU nursing. She has her Master's of Science in Nursing, is a licensed family nurse practitioner, and is a certified otorhinolaryngology nurse. She also, I saw looking at her website for her institution, is a recipient of one of the distinguished awards in her particular practice area. I'm pleased to present to you Elizabeth Gould.
Hi, thank you very much for having me here. I'm excited to tell you all about my tracheostomy team and how I developed it. So it officially started in 2018 and we've had a few different iterations, but we are in a current functioning state and are doing pretty well. So the purpose with our tracheostomy team was to standardize and centralize our tracheostomy care and our resources. When I started my position, I was tasked with updating policies and management of our trachs in the hospital, and pretty quickly realized that I needed a group of clinicians to work with me so that we could do ongoing support and staff education and roll out initiatives. So I identified the RT department as that group of clinicians to work with because they are airway specialists, they see all of our trach patients, and they go throughout the hospital. So the trach team is coordinated by myself, and I work with the RT department. We have 6 RTs that are on the trach team, and that is by volunteer. And we have a very dedicated group, so that has helped a lot with our sustainability. We did a lot of education to onboard the RTs and then have done ongoing education with the group. The respiratory therapy department has been very supportive of our initiative. So this was an unfunded project, just a way that we decided to manage our trachs in the hospital. And so they've been very important to the sustainability of our trach team as well. And I want to acknowledge our ENT laryngologist, Dr. Maggie Kuhn. She is not part of the tracheostomy team formally, but she has been my clinical support person for my on-the-job learning about trachs and about has helped me think through all of our policies and the way that we manage our trach team. And so when I developed the trach team, I included a website that is an intranet website so that staff have an ongoing place to find all of the resources that we have developed and all of the contact information that they might need. And we have approximately 30 adult trach patients in the hospital at a time. And the billing for our trach team is only through the RT education that's done. We don't have any other business plan for our group, but we would like to develop one. So that is something we are working on. So the way our team functions is we have a trach team RT assigned to the group daily, and they usually have half an assignment, and that is combined with a trach designated floor or being the action RT. And we found that the action RT actually works very well for the RT department's staffing and also for the trach team function, because it gives some flexibility to the assignment. And if the staffing in the department allows, they are out of the count. So the RT on the trach team rounds on our all of our trach patients once weekly. And what they do in those rounds is they do bedside equipment checks. They check to make sure that the patient has the appropriate trach care orders, that their airway is documented appropriately. They do skin checks and speaking valve placement assessments. They look at candidacy for decannulation. They look at cuff pressure issues and provide trach sizing support to staff if they need it. They do all of our routine trach changes. So those are the monthly trach changes we do for our patients and the ones that are as needed for downsizing and other such things. We also manage a specialty tracheostomy tube inventory for the hospital. So we have our regular trachs that are stocked in our distribution, but we also have an array of different specialty tracheostomy tubes that can be accessed through the trach team, and we maintain that inventory. We have developed a pretty robust tracheostomy discharge teaching program, and that includes a video that is on our hospital TV system, a booklet, different charting. We support the various teams with figuring out supplies, DME orders, making sure the patient has all of that in line to go home. And because I'm an ENT nurse as well, I also have the trach team support our laryngectomy patients that are not on our designated ENT floor. So if a laryngectomy patient is admitted for non-ENT reasons, we want to make sure that they don't fall through the cracks and they get the appropriate care. So our trach team will round on those patients, make sure they have their orders and their supplies, and that nursing is aware of their airway and knows how to manage it. The trach team can be contacted by Vocera, which is our kind of walkie-talkie nursing system. Probably people have something similar. So you just call the tracheostomy team and somebody is logged into that group every day and answers the calls. And you can also place an evaluation order. So this is a screenshot of our trach team evaluation order. So you can see that there's various reasons why an evaluation order might be placed. So discharge education, cuff leak evaluation, trach tube changes, access to supplies, just a general trach evaluation, discharge education, laryngectomy support. And then this daily tracheostomy patient list is something that's really integral to how we function. And it's a daily list of all the trach patients in the hospital that is emailed out to the group. And that includes the patient, their location in the hospital, their airway description, so what kind of airway they have, when it was placed, and the number of days since insertion. So that is an ongoing ticker for us to make sure that we are doing routine trach changes for our patients. And then it includes the evaluation order, the reason for the evaluation order, any comments, and then the date of service. So we drop a tracheostomy team rounding note on our patients once a week, as I said, and the date of service when that note was dropped will show up on our rounding, on our list here, so we know when to round on patients. So we really depend on that, that daily list of trach patients. This is what our rounding note looks like. So again, we try to round on our trach patients weekly, and the note includes different things like the service that placed the trach, when it was last changed, what their upper airway looks like, if they're on a ventilator, what their cuff pressures are, that we check their airway in the chart, because like I said, we depend on that, that being accurate for a lot of our functions. And we look at discharge planning and put in any backup bedside equipment that might be needed. And it is filed under a tracheostomy team service. So I created that so that our notes could be found easily in the chart and distinguished from other RT notes. So that's been very important to making us visible. So tracheostomy staff education is something that we emphasize a lot. We do a lot of, and so the trach team is involved in a lot of different teaching efforts, and we do tracheostomy classes twice a year, and that's mandatory for all the new RT hires and the trach designated floors. A lot of ICU nurses take that class and nurses from around the hospital. We do have the trach team RTs participate in the ENT patient care classes. They talk about the trach team and our trach management in the hospital. They do new nursing orientation, both in the hospital and ambulatory care. We've done education with the ENT clinic, the PT group, home health nursing, ICU fellow orientation. We do a lot of ground rounds for different services in the hospital, talking about how we manage trachs and what resources we have for those. And we also do a lot of unit skills days. So anytime we get a request for education, I have that group of trach team RTs that is ready to participate. I have some outcomes that I can share. I'm working on a quality improvement project to kind of help capture some of our outcomes, but these are our readmission rates for the tracheostomy patients that have been discharged home. And this is our length of stay. And so I don't have any statistical analysis of this. I don't know if there's any significance or any of that, but it looks like there's some trends in the right direction. So hopefully that there's something there that will be worth sharing. And I don't know what that spike is. I have to investigate that. I have not done that yet, but it was not during COVID. It was prior to COVID, I believe. So anyway, working on these are preliminary results. So we have emphasized placing speaking valves on our patients. We weren't doing a great job of that, unfortunately, in the past. And so I think we have a pretty good trend in the right direction. And we also have a decreased incident of trach-related skin breakdown. We did convert to the Shiley Flex with the flexible trach plate in 2020. But I think we have a pretty good overall trend there. So some outcomes and next steps, as I think everybody involved knows, trach patients are a diverse patient population, representing a lot of different acuities and different medical complications. So it's just been kind of hard for me. It's been a challenge for me to capture outcomes on this group. Historically in our system, we weren't really set up to capture this type of information and quality outcomes on our trach patients. So over time, I keep adding tracking measures and coming up with different ways to track these and get outcomes. And so, over time, I keep adding things, but it's hard to capture something for different research that I've been trying to get done. But, and I've also found that as I've done more education in the hospital, that our incident reports keep going up. But I think that is probably a good thing because there's more awareness about issues, and nothing, you know, incredibly adverse has happened. So I don't think it's a bad thing. And so I'm working on that QI write-up. And then I'm also trying to get more data to write like some sort of a cohort study. And I also think about qualitative studies that might capture how effective we've been and how other people might have be viewing our resources and the services that we offer. And we are working towards a full-time trach team RT, but we need more evidence and a business plan. So I am looking forward to hearing what other people have to say about their trach teams. And we do work closely with our speech language pathologists and you know, some different staff in the hospital, but they haven't been a formal part of our trach team. So looking to integrate that as well. Thank you.
Thanks so much, Elizabeth. That was a wonderful segment, and it's really just remarkable what you've built at your local program, especially without a dedicated funding stream. And I think that there's a lot that we can all learn from your experience and from each other. Now I'm going to introduce Dr. Christopher Baker. So Dr. Baker is an associate professor of pediatrics. He's a pediatric pulmonologist and director of the ventilator care program at Children's Hospital, Colorado. He's also the associate director of the Pediatric Clinical Translational Research Center of the Colorado Clinical and Translational Science Institute at the University of Colorado School of Medicine. After undergraduate studies at the University of California, Santa Barbara, he completed medical school, pediatric residency, and pulmonary fellowship at the University of Colorado School of Medicine. His clinical and research interests include bronchopulmonary dysplasia and home mechanical ventilation. He's authored a large number of peer-reviewed articles, including the 2016 American Thoracic Society Clinical Practice Guidelines on Pediatric Home Mechanical Ventilation and the recent ATS Clinical Practice Guidelines on the outpatient management of post-prematurity respiratory disease. It's my pleasure to introduce to you Dr. Chris Baker, who's been a wonderful friend and colleague contributing to the efforts of GTC. Go ahead and take it away, Chris.
Great. Thanks, Dr. Brenner. It's an honor to speak to all of you about our ventilator care program in Colorado. It's in an acute care facility, our Children's Hospital, Colorado. And I'll get to this, but we don't have a subacute facility for children in our state. And so this program really serves to have kids transition from inpatient care to the home setting. So it's truly all about collaboration. We know this. I think what's kind of unique about the origins of our program in Colorado are the ties with neonatology and pulmonology. And it stems back to my mentor, Steve Abman, and John Kinsella, neonatologist, Jason Geen, just people that were really caring for the sickest premature babies and with other neonatal lung disease who couldn't really tolerate weaning and from the ventilator. And so they ended up requiring or benefiting from chronic ventilation. And it takes a village to do that, as we know. So of course, otolaryngology and our other medical colleagues are critical. Nursing, you're going to hear from our coordinator, Jess Dawson, who has really been involved in our program for decades, as Dr. Brenner mentioned, with working with new graduate nurses and respiratory therapists, and really just helping lead our interdisciplinary program. Respiratory therapy and speech language pathology have like this partnership role that is really critical to the inpatient and outpatient management with things like one-way valves, capping, liberation from the ventilator, all of those things. And I always say developmental therapists are like how the why we do all this, so that the kids can thrive, grow, develop, and learn to do things. And then case management, social work, child life, all of them, like it doesn't work without them. And the families, like that's, I think, of course, for any patient with a trach, even adults, they're going to need help of support from their families. But with children, infants especially, it's absolutely those are the people we're educating. And so we focus on transitions, the conferences and personal discussions, really focusing even the early discussion first of whether to go down the road of chronic ventilation, trach placement, getting them out of the ICU to our pulmonary floor, kind of getting them ready to go home, subacute care. Like that is often a location and an option in a lot of centers, not in Colorado, like I mentioned, but that hospital to home process, and then the follow-up down the road. And we do clinical meetings. We have a weekly bedside meeting in the NICU where we talk about the patients there who are really a challenge to get stable on home ventilators. And, we're really working through their transition, getting them on chronic ventilation settings and kind of that acute to chronic transition. And then a discharge readiness rounds that's more for the patients out of the NICU that are closer to getting home and focusing on their DME, parent training, and arranging home nursing. And I just always emphasize that this impact on families of our program, although it's such a benefit to kids and families, it's hard. I describe it as a traumatic stress and nothing short of that. I have some parents have told me they've been diagnosed with PTSD, but regardless, these are critically ill patients that end up having higher mortality, higher acuity, long lengths of stays. And, I just like to emphasize that. We wanted to standardize our process, really knowing that we didn't need to reinvent the wheel every time. And so we spent a few years when I first became the coordinator or the director of our program, focusing on this. It's QI because what works for us might not work for others, but we did publish it thinking that the process mapping approach could work elsewhere. We focus on care coordination and case management. We summarize caregiver responsibilities so the families know what to expect. Even though the process is standardized, I always emphasize it's got to be customized for each family. The parents want to hear that it's a custom approach. And we developed a family-friendly roadmap. And through doing this, we reduced length of stay overall by 42% and post-ICU by 55%. This is our process map. I'm going to take about the next 45 minutes to go through it all with you. No, actually, obviously not, but even just the steps here, we've had to revisit this a number of times. The upper right corner yellow box is the tracheotomy surgery, so there's a lot before that. And then there's the steps heading forward. There's a vertical dotted line kind of in the middle of this slide. That's where the patient is medically ready for discharge. And then everything after that is all the steps to get them home. We used this map to create our roadmap for the families. And so this gets laminated. We have English and Spanish versions that are on the wall in the patient room. So families like to check the boxes as we go along. And I always emphasize education isn't a box that you check. It's from start to finish. So you see it there all over. And yeah, this map I really think is helpful, like I said, for helping families realize the progress they're making. And so through using this is an eye chart looking at each dot here on this graph is an individual patient's length of stay. And as we implemented our standardized process, you can see the reduced length of stay really dropping from 112 days to 50 days. And that's just about, this figure is post ICU. And that's the 55% reduction I mentioned already. This is the published data. And so you see this 112 down to 49, the two black columns there, looking at that decreased length of stay. Now, the reason the slide is this way is because it hasn't stayed that way since this time. So if you advance the slide, you'll see my next column here in 2019, there's a home nursing shortage. This is described in the literature. It's a huge problem around the United States, probably globally. And we were back up to numbers similar to back before. This is when we added our coordinator, Jess, you'll meet her, but with the addition of a ventilator care program coordinator, again, I'll point out ours is a nurse, We just heard about UC Davis having Elizabeth Gould as nurse practitioner. Other programs use speech therapists, respiratory therapists, but having a coordinator who's kind of the ringleader of things, you could see that it came back down. And I'll still say that 2021 with COVID, with social challenges in certain families, the numbers aren't going to look super pretty. And, you know, it's kind of, we're always trying to address these issues. And so challenges, I mentioned the high point prevalence. You know, we cover patients from 7 states, and so we're discharging them to often rural areas. The changing Medicaid in Colorado to be able to support a subacute facility is very difficult due to legislation that exists. The discharge barrier that's probably the most huge is that shortage of private duty nursing. And that's, like I mentioned, Sarah Sabatka at University of Chicago published that 96% of survey respondents from around the United States described a lack of an adequate supply of home nursing. So rather than end on that note, I'm going to end with some fun stuff. This is our Trach or Treat. Halloween's my favorite holiday, so I love seeing the kids dress up. It's kind of small on the slide, but look down in the bottom right corner, our patient with a trach who is dressed up as a little old lady with the curlers. That's just amazing. And then after Halloween, we move on to the Christmas time holiday, and they convinced me to dress up as Santa. So you can see before COVID, I would hold the babies with trachs and ventilators for like a picture. And we decorate the patient's rooms. If they don't celebrate Christmas, we'd use, festive decorations for their holiday of choice. And then with the pandemic, of course, I had to wear PPE, and you can see that Santa, people at the hospital would say Santa got a Peloton for Christmas, as I don't fill out the suit quite as well as maybe the classic Santa Claus does, but I, poked an extra hole in the Santa belt, and it's fun to go around and see the kids. So anyways, thanks for the opportunity. And you're gonna hear a little more about our program from our care coordinator.
Terrific. Well, thanks so much, Dr. Baker, for a really outstanding talk. And there's some call outs in the discussion box, just noting that some of the seminal work that you've done has been extremely helpful to other people. For those of us that work in the patient safety and quality improvement space, I can appreciate that it's sometimes a lot harder to get that work out, especially into top tier journals like Pediatrics. We have a big thank you from Pamela Almeida, who has adopted your roadmap for use at their facility. I think many others have done likewise. So thanks for that, and also ending on a high note. So now we're going to transition over to Jessica Dawson. So Jessica has been a nurse for 13 years. She began her career as a new graduate nurse on the inpatient pulmonary unit at Children's Hospital, Colorado. She was a clinical nurse on the unit for 12 years and served as the ventilator care program nurse liaison. In this role, she's had the opportunity to participate in and lead numerous process improvement initiatives, research studies, education initiatives for both staff and families, and care coordination efforts. She holds a strong passion for the VCP and the vulnerable medically complex patient population it serves, which led her to pursue the role of the clinical specialty coordinator for the VCP. In the clinical specialty coordinator role, she coordinates program-specific care for patients in the VCP, tracks and maintains data systems, leads and participates in quality improvement, process improvement, and research projects. She also provides education to healthcare teams and families on the management of specific patient needs. She earned her master's degrees in nursing with an educational focus in 2019, and also functions in the clinical scholar role at CHCO, acting as clinical faculty for undergraduate nursing students. So Jessica, I can see that you're clearly the glue that holds this operation together. Why don't you tell us a little bit about what happens on the ground?
Thank you. So I did want to start just by sharing a little bit about my role, the clinical specialty coordinator role. It is a little bit of a newer role to our program, which was implemented in 2019. Really, our program advocated for this role for the ventilator care program, recognizing from some of that data that Dr. Baker shared with you, how medically complex our patients are, how long their lengths of stay are, and really took that data to highlight to the organization the importance of having a coordinator to really kind of oversee the program. So the organization luckily recognized that that was an importance and implemented that role for us in 2019. So I just wanted to quickly touch base on kind of what this role encompasses. So definitely care coordination work, really kind of specifically focusing on getting our families of our patients educated and prepared for discharge, family and staff education, and leading teams in program development, process improvement, quality improvement, and research. And I'll talk about a little bit of that as we go on. So I kind of wanted to focus my portion of the talk on educating families, and I'll lead you through a quality improvement project that our program did as a multidisciplinary team to improve upon educating families. But to first give a background of how we educate our families to care for these patients at home. Obviously, very medically complex patients that require a lot of care, and their families have to learn a lot before they go home. So this is a quick overview of some of the modalities that we use to educate our families before they go home. So a lot of our education is performance-based education at the bedside or in a classroom setting, really utilizing the teach back method. So meaning we teach our families how to do something, skill, knowledge, and then we have them teach that back to us to demonstrate back that they understand the concepts and that they have the skill necessary to take care of their child at home. We also have an array of videos that our families can watch on different aspects of care. We have a caregiver manual that all of our families get right either before their child gets a trach or right after their child gets a trach to really highlight all of the knowledge and skills that they'll need to care for their child at home. We have all of our families go through a CPR training class before they discharge. And then we also have all of our families go through high fidelity simulation, which is something that I wanted to highlight for you today. So our high fidelity simulation program is a great example of a program that we have that really took the dedicated effort of our multidisciplinary team to make a reality and to make a success. So this program was developed in 2014 as a quality improvement project. It was sort of in that bucket of work that Dr. Baker talked about, standardizing our discharge and education process. So this was part of that work. We did some publication and dissemination on this project. We were really proud as a program of this project because it was one of the first programs in the nation to use simulation for family education. At the time, simulation was really well documented in the literature around staff education and education in medical schools and in nursing schools, but there was really a gap in literature around using high fidelity simulation to educate family caregivers. So we really took that opportunity to do this QI project and then disseminate that work. Our high fidelity simulation program focuses on emergency preparedness in the home setting. So really we have our families go through a couple emergency scenarios in our high fidelity simulation lab, where our families can take the lead on their own without staff present in the room with them to really manage a couple emergency situations that might happen at home. So they have that hands-on practice before they go home, and then they can take away any learning needs that they have prior to discharge around emergency preparedness. We really like this model. There's obviously no risk to the child. Families can practice using these emergency skills in a controlled setting without any risk to their child before they go home. It also allows for reflective learning. Following each simulation scenario, we do a reflective debrief with our families, and this really allows them time to kind of sit back with one of our clinicians and do some reflective debriefing around how things went in high fidelity simulation and any learning needs that they took away from the scenarios. So to dive into a little bit of data around our simulation program, to date, so since 2014, we have trained 408 caregivers through high fidelity simulation for 195 unique patients. We have an average of 51 caregivers trained through simulation per year. And then a little bit more data to highlight. We do have our families fill out a pre and post simulation eval, so we can gain a little bit more knowledge of how simulation is contributing to preparedness for discharge and that education process that we have our families go through. So this is just a little bit of data that I wanted to highlight for this group. It's 2021 data, so it's not published, but it is data that we manage. So in 2021, we took 43 family caregivers through simulation. And I just wanted to highlight for you a couple questions on that survey and kind of the data around that. So one of the questions we ask our family is, how useful were the simulation scenarios in teaching you how to care for your child at home? It's a Likert scale of 1 to 5, 5 being very useful. So our mean score in 2021 for that question was 4.88. The second question was, how useful was the conversation, the debriefing with the providers after the simulation training and teaching you how to care for your child at home? Again, that Likert scale of 1 to 5, 5 being very useful. Our mean score for that question was 4.86. And then, how has the emergency simulation training changed your preparedness to know what to do in case your child has a tracheostomy related emergency at home? Again, Likert scale of 1 to 5, mean score there being 4.56. And then we ask all of our participants if they would recommend this training to somebody in a similar situation. And in 2021, 100% of our participants reported that they would. So I really like to just highlight how important our families find simulation in training them to take care of their children at home, and how much they really value this simulation training in their education process and preparedness for home. So kind of want to also highlight some of the continued program development that we currently have ongoing, some of the projects that we are currently working on. So these are a couple projects that are currently ongoing for the ventilator care program as a whole, and then some projects that I'm leading out on in this coordinator role. So one is further standardization of our one-way valve use. So we do have some standardization around how we use one-way valves, but really kind of a gap in standardization around using one-way valves for our patients in the inpatient setting. So kind of working on some projects around that. Further standardization of family education. So obviously we have a very standardized process of how we provide this education, but always room for improvement. So we're continuing work on that. And then also continuing work on an unplanned decannulation research study, really looking at the factors that might contribute to unplanned decannulations in the inpatient setting and any interventions that we might be able to put into place to prevent unplanned decannulation events. So with all of that said, really just wanted to highlight that we really, as a program, focus on diversity, health equity, and inclusion. When we're thinking about all of this education that we're providing to our families, all of these initiatives that we have ongoing, we want to keep in mind that diversity, health equity, inclusion is really important. So for diversity, we celebrate our differences and aim to identify how these differences affect what our patients and families need. For health equity, we strive to ensure that all of our patients and families receive the highest standard of care. When we see disparities, we acknowledge and confront them. And inclusion, we ensure that all of our families feel like they belong in our program. So things like bilingual materials, making sure that we're using interpreters. We have a parent-to-parent program where our families can connect with other parents, and having a vent care program parent representative to really give that parent voice to our program. And then also ending my part of the presentation on a high note. This is a really fun quality improvement initiative that our developmental therapy team led. This is pictures of our inpatient play group. So like Dr. Baker highlighted, developmental therapies and supporting the developmental needs of our patients is really important. We focus a lot on medical initiatives and educating families and making sure our patients are safe, which is so important. But we also want to make sure that we're really supporting them to develop and grow and thrive. So these are pictures of an inpatient play group that our developmental therapy team led out on and initiated. And it's a weekly developmental therapy session in a group setting in the inpatient setting on the inpatient unit, where patients and families can get together once a week and really focus on developmental goals, but also sort of that interaction between patients of the same age or around the same age and families. So really wanted to kind of highlight that as our last slide. And Dr. Baker was reminding me that one of our physical therapists recently said something to us that really made a huge impact. And that, in this inpatient setting where our patients obviously have very prolonged lengths of stay, as Dr. Baker pointed out, we really need to provide them with the early intervention that they won't be getting at home right now while they're inpatient, providing them with a preschool that they don't get, with the mommy and me groups that they don't get. So really making sure that we don't lose sight of those very important things along the way as well.
Thanks so much for really just an outstanding talk, Jessica. It's so clear the passion that you bring to this project, and the fact that you're doing high fidelity simulation on the scale of hundreds of individuals is just a spectacular accomplishment. I also really appreciated your calling out the diversity, equity, and inclusion considerations that have always been important, but I think we now have heightened awareness of just how much that matters, and no patients are more vulnerable than those of ours who have tracheostomy. So really outstanding work. Now I'm going to introduce our final speaker and panelist, Dr. Winston Manumtim. So Dr. Manumtim is a neonatologist at Children's Mercy, Kansas City, and a professor of pediatrics at the University of Missouri, Kansas City School of Medicine. He obtained his medical degree from the Philippines and started his career in neonatology at the Philippines Children's Medical Center and at Mercy Hospital for Women in Melbourne, Australia. He trained in general pediatrics at Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx, New York, followed by a fellowship in neonatology at the University of Maryland Medical Center and School of Medicine. He's currently the medical director of the neonatal follow-up clinics and the director of the infant tracheostomy and home ventilator program at Children's Mercy, Kansas City. He leads the chronic lung disease multidisciplinary team within the neonatal intensive care unit at Children's Mercy Hospital. His clinical research focuses on chronic lung disease and bronchopulmonary dysplasia, and he's published several peer-reviewed articles on their short and long-term respiratory and neurodevelopmental outcomes. So I'm pleased to introduce our final speaker. Dr. Manumtim, take it away.
Thank you. Hello, everyone. I'd like to thank the GTC for inviting me to participate in this webinar. As you may know, bronchopulmonary dysplasia remains the most common complications of premature birth. And the infants with the most severe BPD often require tracheostomy for prolonged assisted ventilation. These infants are at risk for complications directly related to their chronic pulmonary conditions such as BPD, reactive airway disease, pulmonary hypertension, or recurrent pulmonary infections. They are also at risk for poor growth, developmental delay, and life-threatening emergency events such as tracheostomy plugging, accidental decannulation, and other causes of cardiorespiratory arrest. In general, here are the healthcare needs of infants and children with tracheostomy with or without a ventilator. They need a complex mix of specialty and primary care. Oftentimes, they require technology that always includes tracheostomy with or without a ventilator, a humidifier, and a suction devices, and often includes added technology such as airway clearance devices, mechanical insufflation, exsufflation devices, supplemental oxygen, monitoring devices such as pulse oximeters, as well as numerous medications that require the use of aerosol delivery devices. They often require 24-hour, 7-day-a-week monitoring. Skilled care is often given by trained caregivers, usually a combination of family members with home nursing services when available, and complex care coordination, including pre-authorization for most services. Additionally, an inter and multidisciplinary care is needed, provided by intensivists, otolaryngologists, pulmonologists, and other subspecialists. Speech, occupational, and physical therapy are also needed. Hearing, in terms of amplification, visual support like corrective glasses can be needed. Developmental surveillance and behavioral issues are also needed. Ambulation, as well as adaptive equipment and complex transportation requirements are also needed. Educational needs, either school attendance or in-home learning. They also need legal and financial support in terms of the very high complex, high intensity, high cost of care. And in addition, cares common to all children provided by the primary care provider are also needed, namely routine care, seasonal immunizations, well child care, anticipatory guidance, and evaluation and treatment for all common childhood infections and disorders. Here is the list of the various care models for children with tracheostomy for chronic ventilation at home, making note of which care models are likely to be successful. The first model consists of a generalist as a primary provider with input from a specialist. The second model is a co-management by the generalist and specialist, both as home providers, each with clearly delineated roles. The third model consists of a specialist as the primary medical home provider, with the generalist playing a limited role as needed. And the fourth model is a hospital-based comprehensive care model medical home clinic. And this is the one that is most likely to be successful. The American Thoracic Society recommends that for children requiring chronic home invasive ventilation through a tracheostomy, a comprehensive medical home co-managed by a generalist and respiratory subspecialist is recommended. Although the strength of recommendation is conditional and the quality of evidence is very low, this recommendation places a high value on the possible medical and social benefits to this intervention and places low value on the potential risks, which may include increased provider time. Our infant tracheostomy and home ventilator program is a hybrid of two care models that have been shown to be successful. It is a hospital-based collaborative care between neonatologists and pulmonologists co-management model, providing comprehensive multidisciplinary care for tracheostomy and ventilator-dependent infants and children. It incorporates both primary and subspecialty patient care in all aspects of care coordination. We provide a comprehensive, multidisciplinary, and family-centered medical home for infants with trach, with or without a home ventilator. Our core team consists of neonatologists and pulmonologists with advanced practice nurses, nurse care coordinator, respiratory therapist, social worker, and nutritionist. We are supported by dedicated otolaryngologists, gastroenterologists, cardiologists, pulmonary hypertension team, palliative care team, psychologists, occupational, physical, and speech and language therapists, and tracheostomy educators. As neonatologists, we are also the primary care providers for majority of our patients, providing well child care, immunization, neurodevelopmental surveillance, anticipatory guidance, and acute illness management. Here is a summary of our general operations and care. Patients are, when discharged, are discharged from the NICU, the PICU, or the general floors. A 24-hour, 7-day on-call physician is available to parents, caregivers, and private duty nurses for live telephone consultation. First follow-up is usually scheduled within 2 weeks of hospital discharge, and then monthly clinic visit either in person or during this pandemic via telehealth. Rehospitalization is in the pediatric intensive care unit with care oversight from trach and home vent physician. The transition of care to a pediatric tracheostomy and home ventilator program usually occurs between the ages of 3 to 4 years if the patients are not yet decannulated. Now I'd like to share some of our clinical outcomes. As you can see here, we take care of infants with different indications for having a tracheostomy, majority of whom have BPD and airway abnormalities. Regardless of what the primary indication for tracheostomy is, the average age at tracheostomy placement is similar, that is between 4 to 5 months of age. At the bottom of the chart, you will see that the age of decannulation or tracheostomy removal varies between 28 to 24 months of age or 42 months of age, depending on the primary indication for tracheostomy placement. When we look exclusively at those infants with severe BPD, about 90% of them have tracheostomy for home ventilation, and only 10% have tracheostomy only, that is without ventilator. Our median age at tracheostomy placement is 4 months, and our median age at decannulation is about 32 months. Over the years, we have increased number of infants with severe BPD who have required tracheostomy, as you can see in this slide. The graph on your left shows that all of our BPD infants have been completely weaned off the ventilator by 4 years of age, and the graph on your right shows that more than half of them have been decannulated by 4 years of age. In terms of rehospitalization, we found that respiratory conditions are the most common reason for hospital readmission. Most of them occur within the first 2 years after discharge. We were also able to demonstrate that with attention to their nutritional support, their weight and linear growth are maintained after hospital discharge. We found that respiratory viral infections are the most common respiratory conditions that bring them back to the hospital. Although few in number, equipment malfunction in the form of tracheostomy dislodgement and plugging are significant events that can potentially put these infants at risk for death at home. As all of us have been affected by COVID-19 pandemic, we look at the prevalence of SARS coronavirus 2 in our patients with tracheostomy and found that only 4 among 68 patients tested positive. This is only about 4% positivity rate compared to 25% positivity rate among adults in the community at the peak of COVID-19 pandemic in 2020. Additionally, we provided important guidelines for infants and children with tracheostomy and home ventilator during their clinic visits or attending school during the pandemic. For longer-term outcomes, we demonstrated that among BPD infants, tracheostomy does not independently impact their cognitive and language development. It appears that the severity of BPD by itself is the major risk factor for cognitive and language impairment. Lastly, we are able to sustain our tracheostomy and home ventilator program by relying on our multidisciplinary team to provide comprehensive family-centered care 24 hours a day, 7 days a week to these high-risk infants in the community. Equally important is our reliance on the family caregivers, professional caregivers, as well as the community at large for their support for this vulnerable population. Thank you.
Thanks for a terrific talk, Dr. Mantum, and really giving us a broad perspective on an area that I think doesn't get enough discussion in our, in many of our conversations around care. And one of the things that came up in the discussion forum actually was long-term care, which is another domain that we may look to pursue either during our Q&A session or during a future webinar. Well, I guess if it's okay with everyone, I think that we'll begin with our Q&A panel. We actually have a wide range of really interesting questions that came up. I'll start with one that addresses an interesting question around communication. So this question is, we have many families that do not read their primary language. What recommendations do you have? We've been trying to do videos on their own phones that they can go back and to review. How do we overcome these language barriers? I don't know if Dr. Baker or Jennifer might be interested in addressing these, or Jessica might care to address these questions.
I'd say that like dyslexia and illiteracy of families is certainly something we've encountered, and using timelines, color-coded medications, figures, the videos like other centers have. I think the most important thing is repetition and practice and demonstrating the ability to do it. And so I think persistence is the key.
Terrific. Would any other panelists care to add to that? All right, here's another question. How do you get the smaller children together with child life? For example, our inpatients are not allowed to leave their room. If they go to the playroom, it is not with other children, and they go with the parent and then return to their room. Does your inpatient playgroup therapy include parents, caregivers, or just strictly staff and patients?
I can answer that question. So I forgot to mention when I was giving my presentation, we did pause playgroup during the pandemic, and we are looking at reinstating it. But prior to when we did have playgroup up and running prior to the pandemic, parents were involved if they were available and could be involved in it. It was a great education opportunity of getting your kid out of the room, getting all of their trach supplies that they would need together and with them, but they didn't require that a parent was there. Our developmental therapy team did a ton of work to really highlight like how we were going to keep our patients safe, how we were going to make sure that they were monitored when they were in playgroup. So that's really how they were able to do that. And we're looking at kind of doing a risk assessment to hopefully bring playgroup back after it was paused during the pandemic.
Thanks for those insights and for such a thoughtful approach, Jessica.
Mm-hmm.
This next question is directed to Elizabeth. And the question is there, this is from Dr. Yang, is there a social worker on your team? And as you are managing multiple units and settings, do you have an implementation science mentor or coach?
So we don't have a social worker on our team. And I don't have a mentor or coach for implementation. It was kind of trial and error. But we are looking to be more interdisciplinary in the future. So we'll see how that gets incorporated.
Well, it's really been remarkable how much you've done on a limited set of resources. And it was interesting, you noted that there were 6 respiratory therapists that were involved in your team that have agreed to participate, which is an impressive cadre, but you're looking to have an individual dedicated respiratory care practitioner. How will that change the way that you approach care of these patients?
Well, our idea is that we would have more time for things like writing articles and doing different projects and kind of advancing the role of the trach team practitioner in doing more like consults for trachs and supporting more cuff leak initiatives that we've had and just more complex trach management. So we imagine the role to be more like more advanced. And then also if we can get a designated role, we can have more consistent staffing so that maybe we could add other people to the team, because right now it's just really based on RT staffing, and that has been, you know, really challenging with the pandemic. So if we can move past that staffing issue and have a more dedicated role, I think we could get more people involved with having more of a designated, consistent role. So that would be the plan.
Terrific. This next question is for Dr. Manumton. Are there many neonatologists who provide primary and specialty care services to infants with BPD and tracheostomy at home in the United States? And also on that note, you had observed in your presentation that we were seeing an increase in BPD. What accounts for that, and how have you adapted your approach in response to it?
Hi, unfortunately, there's not a lot of neonatologists who are actually interested in taking care of trach and home ventilator infants at home. We started our program based on what we felt there was a need in the community to take care of these infants. General pediatricians are very much not wanting to become primary care providers also for these infants, because as you can imagine, the complexity of their medical care. The increasing numbers of severe BPD infants that are requiring tracheostomy and home ventilator support is most likely due to the increasing survival of very, very premature infants right at the very viable period, which is about 22 to 24 weeks. So more recently, more and more centers are doing full resuscitation efforts for these very viable infants. And as they survive, the complexity and the severity of their lung disease becomes even more. So their need for tracheostomy and long-term ventilations becomes higher.
Thank you so much for those insights. Very helpful. We also had a couple of inquiries that related to the use of speech valves, approaches to increase their use, early application, and their role. I know that there are a few people on the panel that bring expertise on this. I know that Dr. Pandian has worked in accelerating application of speech valves, and I know that in some of the programs in pediatrics that we heard about, there have been successes in getting speech earlier. So I'll just open it up to the group.
I think it's a really exciting opportunity for a developing child. And I think it was our speech language pathologist that got me to understand it. We actually started calling them one-way valves instead of speaking valves because of all that they facilitate doing in addition to speech, like swallowing and eating and moving air through the pharynx in a more natural way, smelling, even tasting, mucus clearance, and like so an auto PEEP, so even for ventilation. We've started measuring transtracheal pressure. That's been a published way of assessing readiness for the valve, and it's speech therapy and our respiratory therapy that work together for that.
Just to add to Dr. Baker's comments, just agreeing to all of those benefits about the one-way valve and really enhancing sensory function as well as motor function. So just on communication, really realizing the value and the importance of being able to contribute to care needs, to contribute to comfort needs, and have communication for connection. So we know throughout, particularly throughout the pandemic, that we've had reduced visitors. So we're really establishing those connections and being able to relate to staff and others, both inside the room and outside the room, are vitally important. So definitely enhancing and optimizing early communication facilitates this for the patient.
Terrific. Thanks so much, Amy, for speaking on behalf of the speech language pathologist. One of the things that has been really interesting to me has been that the founding of GTC was very much driven by reducing the number of adverse events and improving the safety and avoiding catastrophic outcomes. But when as we've actually progressed to improving the quality of life aspects of care and finding what our patients really want, and admittedly, this is more from the older patients, because the children don't necessarily always have the ability to communicate as effectively, but what they really appreciate more than anything seems to be the quality of life ramifications of being able to speak and swallow, communicate, and engage in life to the fullest extent, which really the work with the one-way valves has been extremely helpful with. I'll just close with one other question. So the topic of long-term care facilities came up in the discussion, and it was highlighted that for some individuals with tracheostomy, that really does represent their home. Are there any perspectives that those on the panel can share about how the logistics or regulatory environment might modify the approach to tracheostomy care in that setting? Obviously, your situation, Dr. Baker and Jessica, is somewhat unique without a subacute care facility. I'd be really interested in hearing about what special considerations might apply as a function of setting.
I'd just briefly say that we want to be equitable in what we offer as far as, the same medical opportunities, the opportunity to be chronically ventilated would be offered to all families and not just a privileged subset. But having said that it has to be offered in the context of acknowledging the real life social issues that are going to be present. And some families can do the care much more easily than others, and not just their own ability to learn it, but the home they're in, the safety of the neighborhood, the access to home nursing, like if they live in a very rural area versus living in a metropolitan center. So we try to really address and identify all those issues on the front end, and yet there's a lot of need still.
I completely agree with Dr. Baker. This has been one of the biggest challenges that we are facing as well in Kansas City.
Thanks so much for those insights. I think that at this point, I'll turn it over to Amy Freeman-Sanderson. See if there are any additional questions or closing comments for the webinar.
Thanks, Dr. Brenner. So thank you all to the panelists for your wonderful presentations. We will be uploading the recorded presentations to the GTC website, so that will be there shortly. Any questions that have been in the Q&A that haven't been addressed, we will follow up and provide answers as well to those. So in terms of, again, thanking our sponsors for making this education session possible. So with that, drawing to a close, thank you. Please sign up to our notifications for our next, the details of our next upcoming webinar. say thank you very much for your time this morning or this evening.